Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman. On this show, you'll receive powerful insights and resources for rural surgeons. I'm a general surgeon in Northwest Indiana, and this show is tailored around the nuts and bolts of rural general surgery practice. But you'll find topics ranging from practical surgical tips to a host of others, including rural lifestyle, finance, training, practice models, and more. We'll have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. Whether you're a surgeon, other specialist, or primary care, or simply someone interested in healthcare for rural America, I'm glad you're here. Now let's get into the show. Welcome back to the Rural American Surgeon Podcast, and I have today the man, the legend, David Farley, old program director from Mayo Clinic, instrumental in my training and in the training of several hundred other Mayo Clinic residents. Thank you so much, Dr. Farley, for joining us.
Pleasure. Happy to be here.
And let's start with an introduction of you, Dr. Farley. So tell us a little bit how you grew up and maybe your connections to rural, and then what you did throughout your career and what you're doing now and in the future.
Okay. So I'm a rural Wisconsin boy. I was born in Portage, Wisconsin, lived in Pardeeville, Wisconsin, about 500 people, lived in Sparta, Wisconsin, about 5,000 people, screwed around and got my wrist cut and saw the doctor there, a family doc, sew it up for me at age 5. That was kind of cool. Lived in Racine, then lived in River Falls, and I had a very nice upbringing. Had a athletic father and a great mom and an older brother and a younger brother, very athletic family. Played golf at Wisconsin, went to medical school at Wisconsin, and then I joined the Mayo Clinic as a trainee. I was there for 6 years, 5 in general surgery, 1 in research. Then I spent 6 months in Germany as a special Mayo scholar, basically to improve my skills on pancreatic surgery, but more importantly for me, finding a new passion about surgical education, how things were going in Germany. And I didn't like what I saw, and I was thinking we could do better at Mayo. And then I spent the next 31 years in Rochester, teaching and training guys like you and gals that are just as bright or brighter.
And then retired around the same time I left, or just before.
2019, the fall of 2019, before COVID. The last straw for me was Epic. Having to chart in and whatnot. I've, on average, for 31 years, put in about 75 to 80 hours a week. And Epic cost me another 45 minutes every day from what I was doing. And my wife was long since frustrated, and I said uncle at that point. And so I got out. It was good timing.
Sure. And what have you done with your time since then?
Well, I've got a variety of things. I got some grandkids. I'm spending more time with my wife and kids. I love to play pickleball. I'm a gardener. My wife's a big outdoors person, four-wheeler, snowmobiling, hunting. So I operate twice a year. It's each fall. She usually bags 2 deer, so I do a little dissection there. I still do some surgical simulation teaching. I work for the American College on a couple projects that I really hope at some point rural surgeons will get a chance to see these things, interact with them, and find them useful.
Very nice. So a little laparoscopic deer dissection in the fall, and other than that, kind of keeping it low-key.
Yeah, it's open dissection, and it's resection mostly. It's not much dissection.
Very good. So I'd like to ask all my guests, and I think the classic guests are probably going to be practicing rural surgeons, but it's great to get sort of a person that has a different perspective and especially a bent for training like yourself on here. But one of the questions that I'd like to ask is, why is rural surgery special to you?
Well, it's a couple different things. Number one, my uncle was a general surgeon. He wasn't in a rural practice, but he was in a very private practice in Minneapolis, St. Paul. And he was a general surgeon in the 50s, 60s, 70s. And I got to operate with him and help him out in the 80s. And he was the kind of guy that was doing carotid surgery. He was doing tracheostomy, doing a lot of endocrine stuff. He was pinning hips. He was, anything colon, breast, hernia, gallbladder, you name it. In my mind, he was a true general surgeon. And in my mind, the only real general surgeons are rural surgeons and those pediatric surgeons maybe that have a very special practice. So, Mayo Clinic is not a rural practice. I never practiced rural surgery, but I had some rotations as a trainee and in La Crosse and in Hennepin and Shawano, Wisconsin. And I know what I know I loved it. I love the idea of taking care of a community, growing with a community, and being there for your community. So I just took the attitude as a Mayo Clinic program director. I got a chance to touch the lives of about 600 surgeons. Most of those are general surgeons. And I'd say about 1 in 6 have a rural type practice. And I couldn't be prouder of what you and others are doing. Every day I live vicariously through you people. I figure if all those 600 surgeons each do 1 operation a day or even a week, I've had a very productive week as long as it's done safely.
Right. Yeah. Well, trust me, your voice is ringing through our heads. All of our cases as we continue through the iliac, I can hear it every day. Don't worry.
Hopefully it's not pathologic. Hopefully it's helpful.
No, it's good. If it was pathologic, you wouldn't be here. So yeah, we really appreciate it. Let's roll into the how I do it section of the show. So we've agreed you were sort of a leader in bringing the TEP inguinal hernia to Mayo Clinic, talked to a lot of trainees through it. I know that you've broke it down in your head step by step. And so for the how I do it section, there's going to be several people that will be listening to this. There may be students that have never seen it. There may be residents or early trainees. And so with those things in mind, don't be afraid to make it too simple. And I may dumb it down even further and ask you about things. But talk to me about your approach to TEP and the first initial steps.
Okay, so first off, should you use a TEP? And the answer is sometimes yes, sometimes no. And I know it's fallen out of favor, robots, open surgery, but I like TEP, especially in somebody that likely has a bilateral hernia or somebody that has a recurrent hernia that previously had an open repair. I like to get into that virgin space. So they need to be fit enough to undergo general anesthesia. If that's not the case, then I don't want to do a TEP. So let's say we got somebody with a bilateral hernia, wants to get back active right away, like most patients do. And so they need to go under general anesthesia, and in the operating room, they're under general anesthesia. Curvilinear incision underneath the belly button, couple of S-shaped retractors, dissect down to the rectus fascia, not in the middle, off the midline. Dealer's choice, whichever one. If the person was symptomatic with a right-sided hernia, I would probably pick the left side just because the camera might be a smidge further away from the right side, and the further back you can get, the better the picture. So you make a little longitudinal fasciotomy in the rectus fascia, the anterior rectus fascia. You should see muscle. So I usually made a 1 centimeter incision, use those little S shapes, use the big curve, not the little curve, the big ones, and spread, see the muscle, and then get the muscle from medial to lateral, push it out of the way, and then you should see the posterior rectus fascia. And once you see that, you slide your S shape underneath the rectus muscle, hook it underneath the fascia, and you have your balloon dissector gooed up with some goo, whatever it's called. And then you slide it into that hole, and it's a corkscrew, wiggle jiggle. I'm kind of a Parkinson's kind of a guy. I like to, find an easy path, keep the tip up as the tip goes down. And I've had hundreds of students and interns that can do this, so it's not dangerous. Wiggle, 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 keep it anterior so the tip bumps into the pubic bone. So if it's me, with my right hand, I've got the balloon dissector. I got my left hand feeling where the pubic bone is, and this thing is going to slide behind that rectus muscle. It's going to be anterior to the posterior rectus fascia, and it's going to get into that preperitoneal space. It just magically slides in there, and you bump into the pubic bone. And I usually bump, feel it, prove, Lehman, show me, bump it into it, and I can feel that. And from there, depending on the product that you're using, you use the balloon. Some were 10 puffs, some were 30. You get a sense. I always took the camera and looked inside. So now you're inside with the camera looking in the preperitoneal space. And you got to think to yourself, okay, let's get north up. Let's get the pubis straight up and down. And let's get our orientation. Because if you're not oriented, it's a really dangerous and scary operation. So you bump into the pubis, you back up, the balloon's blowing up, the camera slides in, and you can see the pubic bone. And as it inflates, you will tend to see a hint that there's the right pubic bone and there's the left pubic bone. And as it expands, you'll tend to see the inferior deep epigastric artery and vein that might get pushed to the side. It sort of depends. If the person has a direct hernia, you'll see the pseudosac, the hernia sac of that direct hernia and into the balloon. And that would be a first question for me to ask in my trainings. Do you see the pubis? Do you see the epigastric? If it's medial to the epigastric and the pseudosac is there, we got a direct hernia. Doesn't mean there's not an indirect or a lateral defect, but it means we've got that and we need to fix it for sure. So once we get it dissected, that balloon about not as big as a volleyball, maybe half as big as a volleyball, but bigger than a softball. Got to be careful too, as you inflate it, you may cause bradycardia in the patient. You know, let your anesthesiologist know as you put the balloon in to say, you may need a little help here with the bradycardia. And if that's the case, I always deflated the balloon and let it collapse, let the anesthesia figure that out, put a little more fluid on board, and away we go. So let's say we blow up the balloon, everything's good. I got my S shape behind the balloon, I deflate the balloon, I pull the balloon out. I've got now the pathway into this preperitoneal space. And now I'm going to put my camera in there, hook it up to CO2 and insufflate the pressure. We can argue what the right pressure is, but just remember, the greater the pressure, the more you're going to compress stuff, and you may dissect further than you want. And every now and then somebody gets an air embolism, a little break in a blood vessel, and that can happen. That never happened to me. I don't think. I certainly didn't see it in my visualization of the patients, but I operate on probably 2,500 people and 5,000 bilateral repairs, and so trying to keep the pressure as low as you can. You put the camera in, you open up that space, and now you need access. You've got an assistant. You're really relying on that assistant. So Dr. Lehman can't, in my opinion, run the camera and both ports doing a TEP hernia. So you need a camera person that you can count on, whether that's a scrub nurse, a surgical assistant, a medical student, resident, doesn't matter. But they need to be able to orient this thing so up is up and down is down, and then to follow carefully and keep my instruments in view. I make 2 transverse incisions that are 5 millimeters in size. The first one is just cephalad to the pubic bone. It is in the midline. I would like to hit the median raphe. I would like to split between the 2 rectus muscles, and then I will take my trocar. Once I stretch that skin a little bit, the trocar goes in, and depending on what kind of trocars. When I first started this, I had these razor sharp things that I just loved, but they're dangerous as heck because you impale them, they go into the bladder. So it was always a wiggle, and so barely show it to me. Slow down, Lehman, slow down. You want to make sure this thing just barely pops in. And I've got a few videos that show it, this sudden thing, and it's why I got gray hair now. So you get the first one in. The second one needs to be as far away as possible, but it can't be banging into the camera. So it's about halfway between the 2 of them. It's nice if it's at least 3 centimeters from the one by the pubic bone. Same thing, I make a transverse incision, spread the skin, wiggle down. The camera person's got to back up because that trocar is coming in. And so now I've got 2 trocars in place. I fix them in place and I'm ready to go. When I first started with the TEP hernia, I had typical graspers, just atraumatic or some sort of grasping thing. And now I have these, what I was calling pinchers or just tweezers. And they were so much better than the looped things. And I actually got my thumbs were, arthritic with that. So I got something that I could just pinch. So I put the pinching things in. And then from there, in my mind, it's relatively straightforward. I never use the cautery. I try to avoid that at all possible. And the first thing I do is I want the 2 graspers to come down in, touch together. So if it's you as the surgeon or somebody else you're watching, show me that you know that you're in a little space, less than a softball. It's a tiny space. Bang that together, and then when you move around together with your 2 fingers so that we're not all over the place, that the tips are gone. So once you have that, I touch the pubic bone so you know where that is. If you slide down the pubic bone laterally, iliac vessels are there. I don't want to see those. I don't want to touch them. but that's where they are. Then I want to slide up and I want to find the deep inferior epigastric artery and vein, usually two veins and one artery, and I want to keep it up. Every now and then, maybe 1 in 2,000, the epigastrics would drop down, but keep them up, and from there you keep that up and you dissect. One hand up, one hand down, one hand up, one hand down, and you keep stretching that space, and you get to the point that you're actually, hey, that's the internal ring. I'm getting a sense that the spermatic cord's coming around. Hey, I'm sliding out. This is going to be outside toward the transversalis. We're going to see that. And so then it becomes a matter if it's a male or a female. A TEP hernia is a great repair for a femoral hernia in a woman. And I've had multiple ladies come to me after 1, 2, or 3 attempts at fixing a femoral hernia, and nobody went in from the backside, whether that's a TAP, robotically or laparoscopically, or a TEP. But I think if you have a female that has the potential of a femoral hernia, think long and hard about TEP or TAP. So at that point, I'm looking to find, is it the round ligament of a female? Is it a male? And I'm looking for an indirect sac, that sac that goes around that corner up into the internal ring. And it's hard to describe, but at some point you're looking for this whitish sac that invariably in my mind I'm grabbing with my left hand. I'm putting traction on it. I'm pulling it kind of toward the pubis. And then with my other tweezers, I open up the grasper in the bottom part, like my thumb. I'm going to find that white sac and sort of push it, being careful that the top of the grasper doesn't hurt the epigastric or hurt anything. I'm not pass pointing, but I'm kind of scraping like a shovel on a sidewalk that sac, and the sac is pretty firm. And at that point, it becomes a game. All right, I don't want to put a hole in the sac, but I'm trying to create this deflated balloon and get it in back at some point that it's going to fall back and be out of the internal ring. I look at my direct spot. Is there a direct hernia there? Doesn't matter if there is or not. I just need to know that because I am going to put mesh over both those spots. And then I will look at the iliac vessels or where I think a femoral hernia should be. And there have been many, many patients that I did the triple on one side, and I've even had one lady with 7 hernias, 3 on one side and 4 on the other with an obturator hernia. And depending on how you cut the mesh, you can cut them all. And you know what a great advantage looking from the inside, whether it's a TAP or a TEP. You can probably see more. You got a wider view with a TAP. You can see the appendix and the bowel and whatnot. But with a TAP, what I didn't like about the TAP is now you've got some transverse incisions and you've got a more likelihood of developing a hernia. Whereas my incisions, if I'm doing a TEP, I got 2 that are 5 millimeters. I never had a hernia through one of those. And that infraumbilical incision, as long as you make the incision on the anterior rectus and keep the posterior intact, I never had a hernia there. So it was 5,000 times doing that, not having a hernia. And I know there's people that have hernias with lap choles, with TAPs and whatnot. So that's an advantage. A disadvantage, it's a smaller space. You got to be careful, but it's one of those things like anything else. When we get repetition, you get good at it, and you can do a bilateral TEP in 22 minutes. I did one case by myself in my 31 years at Mayo. It was me and a first assistant, Brad, and we did a bilateral TEP. We didn't have any trainees. They couldn't make it. They were busy. They were tied up. And so, all right, from skin to skin, 22 minutes, that's what we're shooting for. And I always, selfishly or badly, I always said, I'm willing to do this in an hour. And I will let my trainees struggle some as long as I'm coaching and they're making progress. And if they could get the one side done in 45 minutes, then I'd, switch on the left side and say, let's not spend 2 hours and fix this. Let's do this in 60 minutes if we can. So if you've got it all dissected back, the TEP or the TAP, you can see the genitofemoral branch, the nerve. If the person's skinny, if they're fat, you probably won't. The lateral femoral cutaneous, you'll see it if they're skinny, if you know where to look. But if they're fatter, then you probably won't. I try not to mess with any of that stuff. And the piece of mesh ideally is about 4 inches by 6 inches. I usually, instead of a rectangle, I trimmed off part of it that I was going to put it on the pubic bone. I didn't want to put the mesh down where the bladder would have more access to it. And I had actually one urologist at Mayo, God bless him and rest in peace, that was tough on me. He was really upset that I did a TEP because he wanted no part of that with doing any bladder operations that might get stuck down there. So because of him, I always trimmed off the corner to try to minimize putting the bladder up against the mesh. And then putting the mesh in place, there's a variety of ways to do that with a tacker, a permanent, absorbable, with the what do you call that, Velcro-like stuff that sticks in there. I did a study with that. I did 20 in one arm and 20 in the other. That's a terrible study. It's not big enough. But I had one recurrence with the Velcro, and I didn't have any with the other, so I stuck with my own tack. I started out with metal clips, and by the end, there was a absorbable thing. And then invariably, I would say a couple tacks just on the anterior edge of the pubic bone, meaning Cooper's ligament, a little fascial, anteriorly on one side of the deep inferior epigastric, and I put a couple up top, out laterally, but I wouldn't put any down below. I'm not looking to hurt any sort of nerves, and any tack has to be above the inguinal ligament, so I should be able to feel it. If you're out lateral and you can feel it, you're not going to hurt any nerves there. If you can't feel it and you're feeling for this and you're pushing, you might likely hit the lateral femoral cutaneous nerve. And I did operate on 4 or 5 people that came to Mayo with injuries from surgeons that, tried their best, but, nailed that thing. So I'm sorry, that's a soliloquy. That's a lot of babbling. What can I explain better?
No, it's perfect. I didn't have to lead you through anything, but I did have a couple follow-up questions. So first off, when you're placing the mesh, you're describing cutting, I assume, a flat piece of mesh, right? Not a pre-curved or pre-shaped mesh. Is anybody
Correct.
doing TEP with a pre-shaped mesh?
Yeah, I never used it. That stuff existed and had some flaps and whatnot, but I was very happy with the flat piece of mesh. It was much easier to manipulate. It was quicker, and I thought my patients, from the inside, I really liked that advantage of having a hole and the mesh being on the inside, so it's pushed right up, blocking that hole, as opposed to Liechtenstein is a wonderful repair and it's great, but I'm always nervous that I'd rather have it on the inside.
Any special tips for when you put the mesh in to label it to make it easy to unroll and oriented well?
Good question. Yes. It's been 5 years since I've done one, so I forgot to say that. So I've got my mesh, and I've cut off this triangle because that's going to be on Cooper's ligament. So I'm going to eventually try to get it in there. So what I'd like to do is fold the top down, fold the bottom up, make it 1/3 the thickness. Grab the medial aspect where that triangle's off, grab the medial aspect, slide that mesh in so it's going to open up with the top. Let's say I'm fixing a right-sided hernia. The top's going to open to the right and the bottom's going to open to the left, and the triangle is going to be on the left side. At that point, I take the 2 tweezers and tap the mesh down so it sits on the bladder. And at that point, it's usually, famous last words, 2 moves. The left hand grabs the top of the mesh, the middle of that mesh, if you will, not down by the triangle, but on the top anterior side. I'm going to grab that up, sort of put it where I think it belongs, maybe just lateral to the epigastric, and my right hand is going to come in and sort of swat this thing away, and it's kind of a letter opener. Sometimes it would roll, and you just slide it along, and the top falls in place. But, sometimes it was screwy, but if you grab the mesh with a big bite and not crinkle it, but get it at the top, and my tweezers, I don't know, are 1.5 centimeters bite, you can move it around like a stiff flag a little bit, and that works pretty slick. And then you can get it in the spot, tap it in place. That way, the little bit of blood or little fluid, it would stick, and you could see it, and you could be confident that you could tack it easily in place.
Yeah, very good. Well, that's excellent. So the only other follow-up question I have is, if someone would like to learn more about TEP inguinal hernia repair, is there a place or resource, website, a company that you'd recommend that they call to get more information, maybe even training on it if they'd like to try it?
I don't have anybody right now that I would peddle. I would, if somebody wants to, you could send me a note, an email, david55farley@gmail.com. I've got, in the past, when it was Twitter, I probably put 100 tweets on. Some of them are on TEP inguinal hernia. And I do have some, thumb drives, and I've given, a couple dozen, if not 100 talks on it, so that I could send out. I don't have any patents on any of my stuff, and if it helps somebody do a safe operation, I would be happy to do that. Having said that, I would be reticent to just tell everybody, yeah, go right ahead, because I think having a mentor and having a colleague there and coaching you for the first 1 or 2 or 3 or 4 is probably a good thing, because it's nerve-wracking, especially if the camera person changes that thing and up is not up. You can get into real problems. But I'm sorry.
What about ordering the equipment? So, you'd have to call, or somebody at your hospital would have to call the company to get I mean, let me give you an example of where I'm at. So
Yeah.
I'm in three critical access hospitals. We're talking 2 operating rooms, 1 endoscopy suite. I've got 5 total OR nurses in my hospital, 4 techs. And one of those techs is in charge of ordering all the stuff. So if I want a J-tube or anything, like, I just tell them, and I've got to pick it out of the catalog.
Yeah.
So is it BARD or Applied, or who's the best company to call? I mean, I don't have any affiliations.
Yeah.
I know you don't.
Nor do I, and I'm 5 years out. And one of the great things about the Mayo Clinic was I would ask, and there's somebody in charge of ordering all that stuff, and said, okay, do you want a 30-degree scope or a 45-degree scope? We got a contract with Bard or Storts or whatever, and this is what we have. And I said, well, can they come and demo it for me? Yeah, I'd really like that. The American College every year has people demoing their stuff, and other conferences do as well. So, but I'm sorry, Randy, I can't give you the name. My data is all 5 years old and it's biased.
Yeah, that's a great place to recommend if you go to the college and check out some of the booths, and there's probably videos and maybe even practice equipment that you can get your hands on if you're interested in doing TEP. It's probably worth mentioning that, what I do, and I feel comfortable doing a TEP, but I think you need to choose what you want to do. And I have enough people that there's a thing I want to look on the inside. And so I've been doing TAP. I don't have a robot at any of the hospitals I'm working at. Mm-hmm. I use the Bard 3D Max Mesh, which does have a pre-shaped, and I put it in place with the secure strap, which is the absorbable attacker. Mm-hmm. I do the dissection basically the same as what you're talking about, except for dissecting it free. And then everything, when I secure it back up, I use the secure strap. I've had pretty nice outcomes with that. The patient's pretty happy. And then I just, if I have if I have a patient that comes in with a unilateral initial inguinal hernia, especially if it's a man, then I fix that with a Liechtenstein technique. Mm-hmm. If I'm worried about a hernia on the other side, or if I know there's a hernia on the other side, bilateral hernia, they get a laparoscopic repair. Mm-hmm. If they've had a recurrence after an open, they get a laparoscopic repair. The recent guidelines say that all women should have a laparoscopic repair because of the femoral and everything. I got a little too cavalier on that with one and a patient that had multiple previous abdominal surgeries. And then I kicked myself because of the way the operation ended up going, because there's tons of adhesions on the inside. And it was a unilateral hernia. It's just a palpable little marble. And I should have just done her open. So take all the guidelines with a grain of salt, obviously. And I'm not the end-all be-all for surgery. That's why I've got people on. And mostly I want to use this how I do it segment to show that there's key steps that have to be accomplished in every operation. Mm-hmm. But there's tons of ways to get that operation done, and there's not a right or wrong answer. And sometimes I would feel like I'm out in, you have to make a decision. That's the thing about surgery, and you have to decide what you are going to do, and you have one time to do it. It's a lot of pressure, I guess, on you. And to know that there's a lot of people doing it a lot of different ways, many things there's not a right or wrong, is a little bit more settling,
Yeah, I'm not going to argue with you. I think a TAP is a great approach. Having said that, I smirk a little bit to say, what if you'd have done a TEP on her? You'd have been pre-peritoneal the whole time. You probably would have been a piece of cake. Having said that, your point is a good one. You get good at something, then that should be your go-to for the most part. And if your other choice is a Liechtenstein, I'm not going to fault that one bit. Not a bit.
Some of her lower operations, I can't remember the details, but if it wasn't a lower midline, it was at least a fan and steel. So what do you think about that? Like if somebody had a radical prostatectomy or whatever.
Yeah, I tried to avoid it. Yeah, I tried to avoid it. I did a couple. They were doable, but oftentimes I'd have a hole or two in the peritoneum, which I did not like at all. So mea culpa, just like you. If it was a radical prostatectomy, I said, no, I'm not going to do that. Or I would, if the person came to me and said, well, I know you're an expert at this laparoscopic stuff. I said, here's the deal. I will put the laparoscope into your abdomen. I will look from the inside and I'll see how nasty this thing is. And if it looks good, then I'll back out. I'll make my little fasciotomy and slide in and put it in and blow it up. And I can actually look and check and see how it's going. Then I could do that. And I must have done that 4 or 5 times. But, we're talking thousands of operations. So it's pretty uncommon.
Yeah.
I, like you, went.
Let me give you a theoretical situation where a patient has a known bilateral inguinal hernia and they had a radical prostatectomy and you did that and there's just adhesions everywhere.
Mm-hmm.
Would you do a bilateral open in that situation, or would you stage them and do one and then 6 weeks later do the other?
Good question. I would do them both open. I mean, part of that's my practice. I don't live in a smaller town where this person may be coming 10 miles. I got somebody coming from the coast or the Canada or wherever. The truth is at the Mayo Clinic, 75% of all people come within 150 miles of Rochester. But I don't really want people going back and forth. So I would do bilateral open repairs on that person. Good question.
All right, great. Well, let's move on to the next section of the show that's called the financial corner. I just have a bent towards personal finance. I think it makes you more of who you already are. And assuming that most of us are relatively altruistically motivated, I think if surgeons are more in control of their finances, it's a good thing overall for rural surgery and surgery in general. So I'd like to ask if you have any particular money tip that maybe you wish you knew earlier, or that something that worked well for you, or even a financial mistake.
I'm pretty lucky. My father was a saver, was a budgeter. I like Dave Ramsey. I like paying off debt. I don't like to pay other people money any longer than I have to. If you're going to get a mortgage, I like 15 years or less. And if it's a 15-year, I want to pay it off in 6 or 7 sort of thing. But I think Dave Ramsey's point is he oftentimes says, live like no one else so you can live like no one else. Meaning, hey, you're skimming the bone. You saved up money. You worked. I mean, I worked through college. I worked through medical school. I worked through residency, moonlighting, whatnot. So to come off of that, to not have some of the trainees coming through now have over $500,000 in debt. That's a pretty nice house. And I wouldn't want that debt coupled with a house mortgage payment. So get rid of the debt. And then from a savings standpoint, if the company or the hospital or the institution has a 403B or a 401k or has any sort of matching, I'm signed in. What's the max? You give me 7. It's free money. I want the free money. I will be happy to do my thing, but I want your free money. And then my wife and I are good savers, so that we can, when it comes time to buy something, she would always tell me, you tell me never to settle. Don't settle in the operating room. Don't settle, for the address or whatever. Dang, she's right. I don't want her to settle, but you've saved for this, and save for your kids for college. We have 3 kids, and we saved up every penny so that they don't have any debt. Now that may or may not be a good thing for them, but I like the idea of getting rid of debt, saving money, and as far as investing, I'm a pretty aggressive investor. I'm still not spending any of the money that I've saved. And so I'm weighted toward the stock market more than I probably should be. I'm now in retirement. I'm 63, and I'm actually coming to the point where, dang it, I gotta cash out. And some of this stuff is accrued, and it's like, all right, should I give some stock away and just, be altruistic as you suggest and not get hit with that? But that's what I got to offer. I don't expect or assume to be an expert, but I think there's something to buying and holding. I'm not a big buyer-seller guy, and I am big into savings and getting rid of debt.
I have one follow-up to that. So it does seem that when the time came and Epic's hitting you and that extra 45 minutes a day is too much to bear, that you gave yourself options by living like no one else, so later you can live like no one else. So at what age did you retire? When do you think you could have retired?
Great question. So I retired at age 59. From a financial standpoint, it was a mistake. The Mayo Clinic, the way their pension works, I had 25 years in. I should have worked 5 more years because the pension that I'm drawing now, it's fixed. It's not that good, quite honestly. And it would be double if I would have spent 5 more years. And that has been really nice. But I'm still not 5 years out from my retirement. And I've really enjoyed what I've wanted to do. I think I probably could have retired at, I'm just trying to think, my last child got through college in 2016, and she was well on her way at that point financially. We knew she wouldn't need any more money. So I probably could have retired when I was 52, 53, comfortably, having confidence that this is going to be okay. But again, take a look at what your situation, I don't know anything about your situation or the people that are watching this podcast. But from me at the Mayo Clinic, 25 years got to a nice pension, but 30 years was a lucrative thing. And that's kind of the, what do they call that? The golden something or other at the Mayo Clinic. We kind of keep people hanging on for 5 more years.
Yeah. Right.
Yeah.
Sure. Well, here's the thing. My situation now is very good because I've been extremely aggressively investing and saving, and my personal spending has been like next to nothing. And I also didn't let a good pandemic go to waste, and invested really heavy during that period when everybody else was scared. And so if I wanted to retire right now with my current standard of living, I'm good. And I'm 35. But that's different. I mean, I don't think a lot of people are in that situation. The other thing that I was able to do, speaking of rural surgery, and you mentioned somebody having $500,000 of debt, I think that debt reimbursement deals are very common with rural hospitals in particular right now. And so first off, I would recommend minimizing your debt, because I knew people that were medical students and they were living in luxury condos in Cincinnati and living like they were a physician already, but doing it on a loan. And it's, come on, guys, like, let's use our head a little bit, minimize your debt as much as you possibly can. Don't take out debt for all of your tuition. If you can take family support, do it, all that stuff, work a second job. But then once you minimize that and you get out, there are places, they may not do 500 though, but maybe they will. I don't know. And so calling some rural places and seeing if you can include debt repayment as part of your initial contract, I think is a great strategy. But then once you get the debt gone, I did that, I guess. And so my debt was gone before I left residency because I was paying it off through residency with a stipend with the place I committed to. And so, living frugal and investing. But the thing is, at the end of the day, I'm a board certified workaholic. Yeah. And so I'm not planning what's the right time for a surgeon to retire. I'm definitely not trying to get on the bandwagon and say, all of you guys should retire early or fire or whatever, because we actually need the surgeons, the 1,000 or so general surgeons that we're creating every year, to come out and replace the workforce. And maybe not even retire at 59, but you can then be in control of your practice. You can do things in a way that you can have life and your surgery. You can be more efficient and, not have to take the bureaucratic stuff. You can kind of push back against that a little more, especially if you're able to walk away from it. So those would be my 2 cents.
Agree completely. I think we've had, I probably had a couple dozen trainees that were in the military and had their costs paid and, came out with a surplus of money. More power to them. Key point, I don't want you to be a workaholic. I was certainly a workaholic, 80 plus hours for 30 years. Having said that, I coached my kids' little league teams. I was there for the bowling tournaments, and I was trying to be everything to everybody, but I probably shortchanged my wife a lot. And if I had to do it all over again, I would try to refinagle that. And it depends if you have kids or not. It's great that you have enough money that you're ready to retire at 35. You love what you do. 35, right. That's awesome. At 35, I had one child, another on the way, and wanted more. And a child, it's going to cost you about $300,000 to get to age 18. And if you get 3 of them, okay, you're going to spend $1 million. Your retirement just got pushed back a little bit. And everybody wants to do that in a different way. Some people burn out. I did not feel burned out. I was frustrated, and I wanted more time with my bride, and I didn't want to spend more time typing on a computer. I was still doing 4 to 10 operations every other day and teaching every Friday all day, and it was great. And I miss the education part. I don't miss the bureaucracy and the epic and that part. I miss taking care of patients, but I'm really quite busy doing what I'm doing and happy to do it. And I'm not sure what number you need to be comfortable. You might need 10 million to feel comfortable. Somebody, as you're saying, you're living pretty frugally, then, most people, if doing what you're doing, could probably have 1.5 million, and hey, they're going to be just fine. That may not be true if you've got kids and going to college and you want to help out. And I felt like that was important for my wife and I to do that.
Right. Yeah. Yeah. And there's also a piece of that, which is I'm planning to keep working too. So, maybe I'm being a little flippant, but overall, yeah, it's a great position to be a surgeon and have the power to be able to get that freedom quickly and do the things that we've both been able to do. So wonderful. So the topic that I do next is classic rural surgery. And that's something that's so classic for rural surgery, but for you, not having necessarily had somebody trade you chickens for surgery or whatever, but you've trained a lot of rural surgeons. I'd like to take this opportunity to use this segment of the podcast and talk about training. And when we were preparing ahead of time for this, you brought up effort and feedback. And so maybe you could just wax eloquently on that for a short period of time, and I could ask a few follow-ups.
Sure. So after giving a couple hundred talks at Mayo and all across the planet, my passion is education. And that's what I like to talk about because I like to improve. I like to learn, and I want my learners to improve. And my goal was always to take the most dangerous surgeons in the world, the people that just graduated medical school and start an internship and make them better. And so it took me 30 years of working with that. And it was a long time, but my eventual mantra was going to be, I want you to be better to start so you can do more in the operating room and be safer in the operating room. And to do that, there's 2 things that need to happen. Number 1, the learner needs to put forth effort. The rural surgeon needs to put forth effort. Somebody wants to be a better dancer, needs to put more effort into being a better dancer or golfer or surgeon. And then how do we do that? Besides the effort, you got to have feedback. Somebody, some friend, some colleague, some coach, some mentor, a wife, a spouse, a colleague, a nurse, a medical student, or most importantly, the learner themselves can give themselves feedback. So if we're talking about rural surgery, so I'm going to not talk about golf and dancing, but if we're going to be good at rural surgery, that entails a lot of stuff. How to talk to a patient, history and physical exam. That's not kind of my shtick. I'm talking about technical skills. I'm talking about judgment. How do we become a better, safer surgeon? So the learner has got to put in more effort. What does that mean? If you read a chapter in a book, 5 pages, and you read it, and you read that tonight, you close the book, and you never look at it again, it's very unlikely that you're going to have any long-term retention from that. I'm sure maybe you did it in college. I certainly did it in college and medical school. I highlighted that 5-page chapter. I highlighted the key things. And so I would read it, and the next day I would read the highlights. Yep, I know that. And then maybe a week later, I'd read those highlights again. Yep, I know that. And then maybe it would come to the ABSITE test, the American Board of Surgery in Training exam, or maybe it would become Dr. Saar or Dr. Lehman or Dr. Somebody's going to ask me a question on that. And I can say, it's at the bottom of the page and it's highlighted. What the hell does it say? I don't know that. And so my point is the learner's got put forth more effort. You got to get your brain to work. Highlighting, reading highlights, the brain doesn't work at all. It's almost useless. It's better than nothing, but it's almost useless. What would be a better thing? Read the 5 pages, close the book, and tell your spouse or tell your scrub nurse while you're doing something else or one-on-one, I just read a chapter on thyroidectomy. I want to tell you a little bit what I learned. And what I learned is, and maybe the first time you read that chapter on thyroidectomy, there's 3 veins. There's a superior, a middle, and an inferior thyroid vein. There's 3 veins, but there's only 2 arteries. But there's sometimes a thyroid edema, and that's all you get out of it. But that's better than reading the highlights. You have to generate things. The more you can generate. So if Randy Lehman's my intern way back 5 years ago or however long that was, and we're doing a thyroidectomy, and he wakes up at 5 in the morning and he's taking a shower, if he's into it, if he's into learning, I'm hopeful he's read the night before, and he's got Farley's cheat sheets that has 21 steps on thyroidectomy while he's shampooing his hair. Curvilinear incision, divide the platysma, separate that up, median raphe, down in the midline, 2 green goiter retraction. That is generating learning, a potential for long-term learning. And you can see this, and I saw this over and over again. And I can remember one of my trainees, we did a thyroid on a Monday morning, and I usually put those first cases in a Wednesday morning and a Friday morning. Good trainee, bright trainee, nothing wrong with the trainee. And on the first case, he'd never done a thyroidectomy before. And so I let him do what I thought they were comfortable. They made the incision, they divided the platysma, got in the midline. They didn't hit the anterior jugulars. They got the strap muscles out of the way. They put the clamps on the edge of the thyroid, the cochlear clamps, and rotated up. And sort of the first step is always, for me, is let's divide the middle thyroid vein. It's a safe thing. I don't know how many times, if I did 500 thyroidectomies, I'll bet 100 times we had bleeding from the middle thyroid vein. Mea culpa, because I got a trainee doing it, and I would let him do it. And I said, we're going to ligate in continuity. Okay, what does that mean? Well, right angle comes in, we pass a 3/0 silk up. A right angle comes in, we pass a 3/0 silk up. We hold them up. You tie your side, I tie my side. You tie it a little bit this way, I tie it this way. When we get done, you hold both of them, cut in the middle, and cut to 2 stitches. That's ligate and continuity. We did the same thing on Wednesday. And I said, all right, what do we do now? Because now we're coker's up, thyroid's up. I don't know. I said, what do we need to do? I don't know. And just sort of paralysis. I said, what about this blue thing that's here? Yeah, we need to take that out of the way. I said, what is that blue thing? No idea. What do we need to do to it? No idea. If I helped him one more time through this thing, middle thyroid vein, ligate and continuity. We got to Friday, same thing, same right thyroid lobectomy. Got to the point, put the clamps on. What are we going to do? Didn't know what to do. And so in my mind, Randy, I failed. I failed that young man. I didn't expect enough coming in. At the end of the case, if I really wanted to know that, I should have stepped back. If there was 5 minutes or the next case we were scrubbing, I could have said, hey, how do you get rid of the thyroid vein? Well, you ligate in continuity. Well, take me through that. And if I had done that, and if I did it on Wednesday again, when I came to Friday, I would have had a better learner and better prepared. And so that's what we've tried to do in the Sim Center. And I wanted to comment, if you've got listeners out there, we had a nice model for TEP hernia that you could simulate. It's an inanimate model. It doesn't look completely like the real thing, but it gives you a sense of working in a softball-sized space. But that's what I mean about, effort. You got to put effort in, and it's doing more surgery or reading videos, looking at videos, or if you record your TAP inguinal hernia repairs, which I hope you do, I hope others do, I hope you go back from time to time and look at them. One of the best surgeons I ever trained was my boss, is the chairman of the department at the Mayo Clinic. He's one of the few surgeons that I know that has gone back and looked carefully at his laparoscopic stuff, doing lap Whipples, lap hepatocogeginostomy. And he knows when he screws up, and he's the best critic of it. He asked me to look at it early on. Yeah, but he's better at it now, and he's really good at what he does. And he's put more effort into that. And then getting feedback, well, he's getting feedback because he's looking at it, and he knows it bled like stink, and he made a mistake, and he's giving himself feedback. But there's other people, The nice thing about the Mayo Clinic is there was visitors all the time, and people from Japan or Germany or whatnot would come in there, and I'm doing a TEP hernia. They don't speak the language very well, but I can see them nodding and I can see them shaking their head. And I realize they know what I'm doing and they don't like it. And so I said, time out. Can you tell me what it is that you don't like? And the English would be, I be careful. I don't want to offend anybody, but it would be broken English. And no. You need what, and it, why? Why do you do it that way? And sometimes I agreed, sometimes I disagreed. And the cool thing about having a trainee at the Mayo Clinic, somebody like you, your previous rotation might have been with Dr. Nagorny or Dr. Saar or Dr. Expert. And I would always ask trainees, hey, is there any other way to do this? Well, Dr. Nagorny likes to do it like this. And I'm all ears. He was my program director. And it was like, he does it like that. Why does he do it like that? And somebody like you is sharp enough to pick up and says, he does it like that because it's less tension and less likely to pop the stitch and make it bleed. Okay. I just got some critical feedback and critical learning. That is a better way for them. So effort and feedback, that's what it all comes down to.
So beautiful thoughts. I have a couple questions. So one time when I was a third-year medical student in Cincinnati, on my first rotation in general surgery, I was doing a gastric perforation from ulcer disease, but it was in the fundus, kind of weird, but pathology didn't end up being benign. But I had a great start to the rotation. I was putting a lot of effort coming in at 4 a.m, doing all the things on trauma surgery. I was with I would say just a guy that had a very good respect in a resident that was sort of taking me under his wing. And I was having a really good time with him. I was staying late. It's like 7 o'clock. We're doing this call case. I could have gone home if I wanted to. I chose not to, of course. And I'm in the middle of this case with them. And it was a young junior staff. Everyone was like extremely good spirits, relaxed. And I was just loving it. And we're getting started, and we find this huge hole in the fundus. And the staff turns to me and he goes, "What's your name?" And I said, Randy Lehman. Randy, you ever heard of a Nissen fundoplication? And I hadn't. And so I said, "No, sir." And I just remember the resident just spinning and looking at me and this disappointment in his eyes and just how painful that was. Mm-hmm. Better than lying about it, obviously you got to be honest. But then he said, "Okay, well, anyway, this is a Goodman fundo perforation." And he's just trying to make a joke. And I'm not able to participate in the joke because I didn't have that funda knowledge. Yeah. So what I tell students, because you're great at training interns, and that's what you kind of like spent your whole career doing. And we really appreciate it, but there's trainees that are above that level, and then there's students. Mm-hmm. And so when students are going on a clerkship, what I learned from that is buy one of these superficial review, books, throwaway kind of paperback books that is honestly not going to be 100% accurate, and it's probably a little out of date, but it's going to give you a framework where everything goes. And open that book and read it in a night and just read the bold stuff, because what I tend to do when I read is I bog down on the first page and I get to the end, I didn't remember anything, and I reread it again, and then I'm done. Yeah. So instead, just skim through it so you know now you remembered what page that thing that you're trying to remember was on, but you didn't remember the details of it. Yeah. Now they'll actually remember that. And then you have to do a lot of just-in-time learning. So your trainee that was doing the thyroidectomy was probably not reading about the thyroidectomy or watching the videos the night before, or, I would do a lot of Medscape in the bathroom before surgeries, reminding myself of all the steps. Trainees need to hear this and know this, because if you come and you just show up and it's like, okay, we're going to do this breast cancer case with Dr. whoever. And so what's this patient? So she's ready to go. And he says, this is a male breast cancer patient, right? That's not the place you want to be. Okay.
Yeah.
And you don't want to be not knowing what, some of the basic surgeries are. So you can't even participate in the joke, because it's not just about showing up and working all the hours and trying hard. It's actually, you got to know some things, and that prior preparation that really kind of sets you apart. So I think that's somewhat of what you're saying with effort. And then the last thing is, if you follow up afterwards, like a 3-hit, plan about the surgery, do the surgery, afterwards think about it and do the feedback thing. Do you have any evidence for that, or any studies? Because intuitively it seems like that's the right thing to do, but I know you were also kind of evidence-based as you went through.
There's a lot of studies out there that show you, if you give a PowerPoint presentation, how to give it so people actually retain more. And most of the studies that I know of talk about the best learning happens when the learner themselves turns it back on themselves. What do I know? And I got 5 minutes. I'm going to operate something on the stomach. And a quick look at the anatomy, and I didn't look at fundoplication. Hey, that's okay, and hopefully the people that are teaching realize that's okay. But if you get an opportunity to read more and quiz yourself more so that you don't forget, and do the highlight thing, that's no good. You lose that bit. And I guess I'll give one plug for a book that we created. It's called Mayo Clinic General Surgery. It's published by Oxford, and it has videos, and it has 1 page of text, and it has text, let's say adrenal gland, and it says embryology, it says anatomy, it says physiology, it says surgery, it says pathology, it says complications, and it says whatever. And there's a couple sentences on each one of those things, but within each one of those sentences, something's underlined. Well, that's a link, or this is a movie, this is a video. If you want more, because on the stomach, it will say someplace fundoplication. And if you'd have clicked on that, you'd have gotten the joke. You might not have been well versed, but it's a digital kind of a book. I think it goes for $140 or something. And there's been a lot of people across the country and across the world have sent me a note and said, this is really different. This is really helpful. But it's not being marketed greatly. And I realize that's an expensive dollar amount, especially for trainees. But if you're interested in general surgery, I think it has 30 different categories: adrenal, thyroid, parathyroid, hernia, breast, colon, rectum, that sort of thing. And it's broken down the same way. And it has a lot of video access to it. It has a lot of great Mayo illustrations. And what you're talking about, if you're looking for something to do the night before, which I hope everybody is, and if you're a rural surgeon and tomorrow you're going to do a laparoscopic adrenalectomy, you should review that. You should, and we can watch. And there's a Farley video or the Lehman video, or you can go to the internet. You can find all sorts of stuff. It may not be good, but if you look at it honestly, I think you can actually generate in your brain, all right, I learned I'm not going to do that. And that looks pretty cool. That guy made a good point, or she's really dexterous there. I'm going to remember that. So
we'll put a link to that in the show notes. Can you say it one more time?
Mayo Clinic General Surgery. It's published by Oxford out of London. And okay, I don't know. We'll find that and
put a link in the show notes. Our last segment is supposed to be resources for the busy rural surgeon. I think that works. Okay. Unless you had something else. But I mean, I find myself, my institution buys us a subscription to Up to Date, and I find myself on Up to Date a lot, looking up different things. Yeah. And I feel like there's more to life than Up to Date. We have so many great organizations, American College of Surgeons, SAGES, and then things like this. Those are the resources I'm trying to bring out and make accessible to people. You can't look at all of them, but
the one thing that I will tell you about, it's not out yet, and it may never come, but I'm hopeful it will. Dr. Mike Sarr and I are working through the American College of Surgeons on a project called Operative Decision Making. And quite honestly, I'd like you and any of your rural colleagues, if you have some videos or illustrations, to send them to Dr. Farley, david55farley@gmail.com. We are taking cases. The 2 cases that we've got, and we're trying to pass it through the American College, is making a decision. We got somebody that comes up with a CT scan has got a right adrenal mass. How do you work that up? How do you operate? Should you operate? When you do operate, what do you do? And if there's problems, what do you do? And it's a platform that a rural surgeon, community surgeon, any surgeon, could be medical student, could be trainee, but it's catered to community rural surgeons in practice to say, all right, how do we do this? And it's not the be all end all, but it's an idea to say, okay, here's a case on difficult lap chole. I bet you've had a bunch. And we ask you questions and we say, all right, what would you do next? And Mike and I have gone through this and we said, you know what? The learner could probably give us 6 different things. I think I'd open. I think I'd do a subtotal cholecystectomy. I think I'd put in another port. I think I'd put it whatever. And we've got feedback for each of those answers. And you click on I'd immediately open and okay, that's not unreasonable. But in the interest of education, we're going to push you a little bit. You haven't burned any bridges yet. It's scarred, it's stuck. You haven't got the critical view of safety, but there's a couple things that we think that you can do. And so we're going to challenge you some more. And it's pretty engaging, and I'm hopeful it'll be useful and valuable and financially valuable so that you get credits for whatever you need for recertification. And hopefully it passes on, good, insightful learning.
It's like a choose your own adventure.
It is. And most of the adventure, it's pretty straightforward, but the adrenal case that we got, it's a Farley case. And I'm not shy about hiding things that didn't go perfectly well. I never have been, never will be. And it puts a learner, and the learners that we put in there all of a sudden said, I don't know what to do. And one of the choices is to say, I don't know. And sometimes we couch you and say, well, think about this or that. But other times we said, sorry, not going to accept that. You got to do something right now. This is a bad problem with this adrenal bleeder or crisis or whatever it is. And I think surgeons will find it useful, engaging, and I hope valuable.
So I have you still with me, and I'm going to be selfish here and do a very brief but actually practical how I do it again.
Mm-hmm.
Thursday, 2 days from now, I have a J-tube, so a patient who has esophageal cancer. And so instead of putting a G-tube and potentially ruining a conduit, they need a J-tube. So I have maybe done 3, I think, since I've been out. Mm-hmm. So it's not a common thing that's needed, but when you need the J-tube, you do. First one, I think I did open. Second one, I tried lap, and what the issue I was running into was I was stitching laparoscopically with a 3.0 or I can't remember if it's a 3.0, 2.0, whatever. I was using a regular stitch on an SH needle and then tying to the roof, basically, to the anterior abdominal wall, trying to do my Witzel tunnel. And I couldn't get the stitch to stay, even with the surgeon's knot, because the weight of the bowel would not stay up there. And it kept falling down. I farted around with it for too long, so I decided to open on that one. Mm-hmm. I just did one last week, actually, on a locums rotation in Toma, which is this little life hack that I have, and I love it. But basically, the patient had been diagnosed with obstructing esophageal cancer the day before by the surgeon there. Then I came on the next day, and we did the lap J-tube together. Just to be clear, lap J-tube, one less RVU than open J-tube. So that's an oversight by somebody. But whatever, do the right thing and have fun. So I got that one done with a surgeon assist. And the way I did it is I used a suture passer like you would do with the ventral cortex, cortex suture for the repairs. And I put one on each end, and then I made the hole, that was able to hold it up. And then I stowed my Witzel tunnel over the top laparoscopically. Mm-hmm. I was like, I'm never going to have another one for another 6 to 12 months. And I just diagnosed somebody yesterday with esophageal cancer, and they're asking for a J-tube. So I'm going to put that in. My plan is to use the endo stitch. Did you ever use that device?
I have. Mm-hmm. Not much.
I think it'll make it easier for me to sew the Witzel tunnel. And then I was going to use my suture passer on the ends. I was just wondering if you were going to do a J-tube, did you do any of those laparoscopically? And do you have any practical tips for me?
Yeah, well, again, take this for what it's worth. 5 years with no surgery. And I'm going to bet that the last 5 years I didn't do a J-tube. So I'm at least 10 years out. Having said that, I think planning and strategizing, making your measurements and figuring out, all right, where is this going to sit? How is that, going to angle in? Most times we always talk about going straight in, but sometimes a J-tube lies better with a little bit of an angulated path. And I was just thinking, when you said it was too heavy, I remember that very well. And at one point I had to put in, I said, you know what? I'm at the Mayo Clinic. I have the luxury that you may not. I got another port. I'm going to put a 5 millimeter port. I'm going to ask my medical student to take this grasper. I'm going to put it up here and hold this bowel up and take the tension off of it, because sometimes tension is a great thing. You got cautery or dissections. Woo! I love tension. I don't like tension when I'm trying to suture that thing up. And so that would be, a simple sort of thing. It costs you another port, but sometimes those J-tubes can take an hour and a half, and it oftentimes could have been a 12-minute operation. Having said that, with a young learner, they can pass point and poke a hole right through the bowel. So I think for me, I always try to put in those 4 stitches around the entry, getting my thing in, balloon testing to make sure it was in the lumen. And then I would always sort of pull them up. And Roger Dozwa was a wonderful colorectal surgeon that would sometimes have a patient that he was doing a low anterior resection, and he would have all these sutures down there, but it was really kind of a neat thing, like a parachute. He said, we're going to parachute this thing down. And it was sort of a nice move. And in my brain, I can see it. I don't know that I can describe it, but the 4 points around this jejunotomy, you sort of bring that thing up, and then the camera person's got to back up, and you can't see it. You can't see if they're all up there. And so then you take the one that's closest to the camera and let that go down. You tap it, and oh yeah, I can see the tube coming into the bowel, and the back one's up where it's supposed to be, and the other ones, pull them up slow. Yep, right where they're supposed to. Pull it, and now all 4 of them there. And if nobody moves, they're where they're supposed to be, and you can tie whatever it is that you're doing with relative confidence, especially if you have the tension off the back side. So I don't know if that's helpful or
descriptive. Are those transfascial stitches?
No, they were intra-abdominal. Okay.
So you're pulling up on the stitches now.
You're pulling up on the stitches, and this is where you might need 2 ports. In my mind, I'm thinking to lift that bowel up, and the camera gets a sense of it's up there, and you can tie it, or you can crimp it down. So I remember some of those J-tubes had a gadget you could sort of slide down, and it would crimp it up. Or they had T-bars too. That's what it was, Randy. They had those little needle, and you pushed it through, and out popped this T, and now you're inside the lumen, and you pull the T up to the thing, and then you pull the wire out, and you would crimp it at the skin. That's what it was. It wasn't intra-abdominal stitching. It was the T-bar, and I don't know if that even exists anymore.
Yeah, I know I used it during training once, but it wasn't the slickest thing, and I think I'm just kind of developing this, how would I like to do? Sure. I might have to do some videos, and might be worthwhile for somebody else to see at some point too. Yeah. But I use the endo stitch for my hiatal hernias, and I'm pretty good at it. So, use what you're good at, I guess. Yeah,
absolutely. And send me a video. I'd love that. I'd love to put cases like that out for, community surgeons, and you're the expert. I'm not the expert, but I can look at stuff and say, I don't like that. I don't like that move, and make a comment and whatnot, and then make people generate their own learning. So I'm all in.
Yeah. Well, I really appreciate that. And I'm just so thankful for the time that we've had here together, and also just all the effort that you put in to my training and so many other trainings, but particularly obviously mine, and the community I know for sure in my town is benefiting from you. So to your point, you're thinking about it right, and the way that your impact on the world is greater and amplified because you spent all of that painful time training us. So thank you so much for coming on.
It's my pleasure. My pleasure to work with you and all the rest of them. And I wish you and your listeners well.
Thank you very much. And that's right. Thanks for joining us on this episode of The Rural American Surgeon. Catch us next time. Take care.